Thank you for coming tonight. I'm Cliff Callis. I'm Vice President of the Bothwell Foundation. And on behalf of Bothwell Regional Health Center, we're happy that you're here. We welcome you. I think you're going to find this evening to be interesting and insightful. And we're going to hear from 3 different presenters. And then we will have opportunity for questions, which you may have. And then we'll also have some questions at the end. So if there are things that pop in your mind as we go along, just make note of them and then ask them at the appropriate time. For those of you who don't know, the Bothwell Foundation was started 25 years ago when a group of trustees realized that there was an opportunity to help support the financial needs of the hospital and to provide for things that maybe they couldn't on their own. And so today, the foundation exists to do the same thing. And one of the things that we do is creating fans for the hospital. You know, there's so many great things that happen out there, and the more people that are out telling that story, the better. So again, we want to thank you for being here tonight. And I'd like to introduce our 3 presenters. Eric Jones is Senior Vice President at Ovation Healthcare, where he spearheads the rapid expansion of the firm's newest shared service platform, delivering accounting and finance expertise to community hospitals. Based in Brentwood, Tennessee, Ovation has partnered for more than 45 years with health systems nationwide to optimize financial performance, ensure long-term sustainability, and preserve operational independence through mission-driven support and shared services. In his dual role as Regions Operations Lead for Colorado and New Mexico, Eric designs and implements scalable solutions that enhance client resilience and drive measurable results. With foundation and health system mergers and acquisitions, Eric transitioned into hospital operations early in his career. He has served as Controller and Chief Financial Officer in hospitals across Florida, Tennessee, and Texas. Since joining Ovation, formerly Quorum Health Resources, in 1999, he's led multi-state hospital turnaround initiatives and moved through both corporate and regional leadership roles, consistently delivering quantifiable improvements in financial governance and operational efficiency. Eric resides in Charlotte, North Carolina with his wife, Allie, and their 4 daughters. Welcome, Derek. Please welcome. Obviously, I didn't write any of that. You can tell that.
Nor did I.
Our next presenter is Lori Wightman. And Lori Wightman's father was a hospital administrator and her mother was a nurse. So Lori thought she'd just do both things. Raised in Fargo, North Dakota, she has spent her entire life in the Midwest, North Dakota, Minnesota, Oklahoma, and now Missouri. Lori Wightman has been the CEO of Bothwell Regional Health Center in Sedalia since June of 2019, where she oversees the operations of the hospital and its 21 clinics, nearly 1,000 employees, and a budget of $175 million. Prior to that, she served as president of Mercy Ada in Ada, Oklahoma for 4.5 years. For 12 years, she worked for Alliant Health in Minnesota, where she served as VP of Operations for Regional Health Services. She also served as president of New Ulm Medical Center in New Ulm, Minnesota, and president of Unity Hospital in suburban Minneapolis. Mrs. Wightman is a registered nurse with a master's in healthcare administration, and she has a varied background that includes having held positions as a healthcare consultant, building project coordinator, governor campaign manager, and general manager of a professional basketball team. A woman of many talents.
That's a whole different slide.
So please welcome Lori Wightman tonight. Our third panelist is Marvin Smoot, and Marvin is the Vice President of Clinic Operations at Bothwell, where he leads initiatives to improve patient access, strengthen clinic operations, and support providers in delivering high-quality care. With more than 20 years of experience in healthcare leadership, Marvin is dedicated to advancing rural health, fostering innovation, and building strong connections between patients, providers, and the community. He is proud to call Sedalia home, and he is passionate about serving its people. Please welcome Marvin Smoot. So we have a commitment to get everyone out of here at 7 o'clock. We have a lot of information to present. We're gonna try to keep it on time. We're gonna try to allow time for questions. So let's get the ball rolling. Please welcome Eric Jones.
Thank you all. Get us started here. I want to start the discussion tonight talking about some of the common headwinds facing all rural hospitals nationwide, not just the ones that we encounter here in Sedalia. Before that, I want to kind of briefly introduce who Ovation Healthcare is to you, so you'll kind of understand what kind of work we're doing with the hospital and why. About 45 years ago, many of you probably have heard of HCA Healthcare. HCA has an operating model in the for-profit world that's very successful. About 45 years ago, they decided to start a company focused on not-for-profit hospital operations, and specifically to take that playbook that they have developed in efficient hospital operations and kind of offer that to the not-for-profit world. So that was the genesis of Ovation Healthcare. And as all good companies do, they evolve over time. And one thing we noticed about 10 to 15 years ago was a lot of our rural hospital clients, which is 80 to 90% of our total portfolio of hospitals that we serve, they were beginning to engage and do, trading their independence, doing transactions with these tertiary centers, especially all around the country in larger markets for sure. They were trading their independence in exchange for capital and access to economies of scale. And one thing that we've done over the last 5 years particularly is invest in developing what our CEO, Dwayne, refers to as sort of power plants. We've always had this sort of the historical leadership advisory, which is the traditional management advisory and consulting that we do for rural hospitals. And we've always had the spend management, which is really the longer term relationship that we've had with Bothwell, is you guys do purchase medical and pharmaceutical supplies through our group purchasing organization, which consequently is the same one that all the for-profit operators buy their medical supplies through too. So you get the best pricing there is on the market. So that's been the historical relationship Bothwell has had. Recently, they engaged leadership advisory to come in and add some additional bandwidth in the finance and accounting practice. So those are the sort of the connections with Bothwell today. But you also see on revenue cycle management and then IT technology services. One thing we recognized was that our independent hospitals were going to these tertiary centers for services that they gave up their independence to get the economies of scale in these other portals. So that's why we sort of focused on developing, again, what Dwayne refers to as power plants. Everybody needs power, but you don't necessarily have to develop your own power plant. You can buy the power and let Ovation, that has the scale and the ability to do this, so you buy those services that you need without giving up your independence. So again, this is sort of a summary of where our clients are. We have 375 clients across our entire portfolio. Not all of those clients tap into all of our power plants. Some just tap into what they need, and then others do take on all 4 of our major service lines. But what you can see is that we have a pretty diverse view and perspective on rural healthcare across the United States. So that's kind of what sets the stage, and as to why I'm here tonight, to kind of talk about those common challenges that our hospitals face. Core of my presentation was actually built on the testimony the American Hospital Association provided to the U.S. Senate, actually the healthcare subcommittee back in May of 2023. And the intent of that testimony was really to stimulate policy relative to rural hospitals. So I used a lot of that to sort of build the core of my presentation. But that being said, these are not all of the challenges that we face. There are public universities my home state of North Carolina, University of North Carolina, has an entire public health department that focuses on this. And I can tell you, even today, there's probably PhD candidates out there doing their dissertations on rural healthcare. So it's more complicated than we can encompass in a presentation. But again, we want to give you, sort of an idea of what not only Bothwell but most rural hospitals do encounter. So one of the biggest challenges to rural healthcare is just simply scale, lack of scale. And what I mean by that is just general throughput. The United States population is very, it's very inverted in terms of the land area versus the population. So what that does is it means for rural hospitals is our populations in our primary and secondary services are very sparse and dissipated, which means the actual throughput of patients that go through the hospitals is relatively small compared to some of the urban centers. That obviously makes it a challenge for rural hospitals because there's fewer patients to distribute the fixed cost. Now, when I say fixed, I'm talking about just the basic cost of opening the doors of the hospital. Now, obviously the hospital doesn't ever close its doors, but generally speaking, just the cost to open the door is distributed across a smaller set of patients. And so therefore, that impedes the equation that drives profitability. The other thing with smaller population and volume sizes is it impedes our ability to tap into some of the other innovative plans that the federal government and the state government put together with respect to quality that could otherwise provide other sources of revenue to the hospitals. So that's a clear problem as well. Second one I want to talk about is unfavorable socioeconomic profile. If you're not familiar with what socioeconomic profile is, I'll go through some of these facts, but basically in the last 5 to 10 years, we've started talking about social determinants of health when we talk strategy and development strategy for our hospitals. And basically what that means is there's a belief that 80 to 90% of health outcomes are dependent on things like, the demographics of the patients that we serve. And I actually read something recently that really caught my attention. It said that your zip code can be more determinant on your health outcomes than your genetics itself, which is quite alarming. So I'll go through some of these really quickly. No, I'm not doing well on time so far, but I'll speed up. Generally speaking, rural populations are older than the urban cohort. That means that drives Medicare utilization, which we'll talk about why that's a problem. Adults who describe their health status as fair or poor, about 5% higher on average than urban cohorts. Average per capita income, generally about $10,000 higher for urban versus rural. And I will tell you, as economics of households go, the deficit of cash when all bills are paid, medical care is the first thing that goes, or the first thing that folks don't have money to spend. So that's another disadvantage to rural hospitals. Unemployment is generally higher in rural areas, and then the percentage of Medicaid is generally higher. All of these are factors that are challenging, obviously, to rural hospitals. Social isolation. I talked earlier about the disbursement of our patients. That sometimes leads to delayed care because they don't have access or don't have transportation to get to areas. And so what happens over time in the delay of care, sometimes our patients that are in our primary and secondary service area deteriorate to a point that go beyond the capabilities of the local rural hospital. So we not only lose patients out of the market for that episode of care, but their subsequent care usually takes them out of the market as well. Another big problem for rural hospitals is the lack or the inadequate behavioral and substance abuse care, which anybody that is in our ER can tell you that when patients are in those types of crisis situations, we sometimes get them on their worst days, but their health is deteriorated, and in many cases, nowhere for them to be discharged to, so we end up taking them on for sometimes weeks at a time. And those patients have to have specialized care and allocation of resources that, quite frankly, we don't have to go around at rural hospitals. Workforce shortages, this is one you've probably heard a lot about, but this is pretty impactful, I think. Number of physicians per 10,000 residents, there's about 13 rural physicians for every 31 physicians. That becomes even more acute when you talk about specialty care. As you can see, that gap widens even more. And even when we are successful in recruiting physicians to rural areas, the challenges are sometimes we actually have to subsidize the practices over and above, because again, the throughput of patients just isn't there to generate profitability at the practice level. So again, we have to pay higher than benchmark rates to get physicians to come, and then we obviously have to subsidize the practices, which is an additional challenge. A little bit about RN nursing turnover. I actually think this number is higher now. For every time we replace a single RN, there's lots of things that have to be considered. There's a recruitment fee, the orientation. When we do bring someone on, they have to go through a series of orientations and aren't productive, actually don't touch a patient for a long period of time. And I remember Michelle recently said that for an OB nurse, can be sometimes up to 9 months of training before they touch the first patient. We're footing the bill the entire time for that. And then, of course, rural areas, I mean, all hospitals are having challenges recruiting RNs and specialized clinical care, but when rural hospitals can't fill it, we do have to backfill with what's called travel or locum nurses, and that costs us sometimes 2 to 3 times what a typical nurse would be. Final thing I'll say real quick on rising costs, Medicare on average pays us about 2% more per year. Generally speaking, since COVID specifically, our costs have been increasing about twice that rate. So if we're getting 2%, our costs are rising 4%. That's just the reality that we face. Reimbursement pressures, as I mentioned earlier, just because of the demographics of aging, we're very dependent as rural hospitals on Medicare and Medicaid, which Laura's going to talk about in a little while, generally pay us below the cost of care. And in order for that to work out, there's been federal and state programs that have tried to fill the gap, but even what's called low volume adjustment and Medicare dependence hospital status is actually in transition right now. I don't think they've completely made the decision on whether that's going to continue or not. These are all things that try to fill that gap. The other thing that sort of fills the gap is our commercial managed care payers that generally do pay us higher than cost. But the problem we run into with the lack of leverage with the managed care payers is a lot of times they just tell us, this is what you're going to get, and you get no more. And we also have trouble contracting sometime on an in-network basis for managed care and commercial payers. So that's a challenge as well. And then payers, Dana can say more than anybody, try to find new ways of not paying us every single day. And some of the stories and the individual details of some of the payers and some of the tactics they're using these days are just unbelievable. So we're up against that headwind as well. Last thing, this is the last thing I would talk about really quickly. And this was kind of an eye-opening. I knew it was something I always knew, but until I actually put numbers to it, it was sort of staggering. So just regulatory burdens that all hospitals face, regardless of the scale or the size of the hospital. All hospitals face regulatory burdens on both clinical and non-clinical. Something I saw recently estimated that just for non-clinical regulatory compliance, talking about 5,000 hospitals across the United States, and then add on post-acute providers. Let's say you're up to 10,000 providers. $39 billion, that's not a typo, $39 billion a year is spent by hospitals just paying for the regulatory burden. So let's do some real quick math. Let's say that if there's 10,000 hospitals out there, Bothwell's theoretical share of that is $3.9 million before we do a single thing. Divide that by our annual patient visit. That's $14 the cost before we touch a single patient, before we use a Band-Aid, before we use an aspirin. To put that in context, I think our average reimbursement on that 284,000 patient encounters is around $550 per visit. So you think about 3% of our reimbursement goes out the door before anything really happens inside the four walls of the hospital, other than trying to keep up with these compliance. Point is, the odds are stacked against us. So, any questions you want to
Very
wait to
good.
the end, or?
Anyone have questions for Eric? Happy to come around and let you sing in the mic. Okay. Lori?
Okay. Hello, everybody. Okay, we're going to talk about how we get paid, but first I want to make sure we all start on the same page. Bothwell is an independent, proudly independent hospital. We are not for profit, and we are city owned. And even though we are city owned and always have been, we have never received a tax subsidy. That always seems to, come as a surprise to a lot of people. And the finances between the hospital and the city are completely separate. There's no money that goes back and forth. When I talk to new employees, I always say, even though we're not for profit, that doesn't mean that at the end of the day, we don't need to keep more than we spend, but instead of that profit, if you will, going to shareholders, it's reinvested in keeping up with technology, in keeping our 96-year-old building going, in educating our talented employees. So it's reinvested into the operation. Now, how we get paid, I'm gonna make it sound like this makes sense. It doesn't, especially to a normal person, because charges mean nothing, really. They did it, I think, at some point, but they don't really, because really no one pays charges. We have some contracts that pay a percent of charge, but if you look at the dotted line, that is the cost of providing care. And you can see, and these are actual Bothwell percentages. 23% or 22% of our volume is paid by insurance companies, Blue Crosses of the world. And you can see that they pay more than their fair share. They pay more than the cost of providing care. And you can see that 78% of our care is mostly governmental, a small percentage of self-pay, but those governmental payers, and we've lumped traditional Medicare and Medicare Advantage together. Medicare Advantage pays a little below the traditional Medicare. We've lumped those together. Those pay below the cost of providing care, so you don't make that up in volume. But that's where those other payments that have come to be, disproportionate share, low volume. There's some other ones that have tried to fill that gap, but those type programs are always on the chopping block in Congress, and so it doesn't quite fill that gap. This used to be called the hidden tax that really employers were paying, because most of the people that have insurance, they get it through their employment. And certainly there has been downward pressure all around. Employers are saying, we can't absorb any more cost, increases, double-digit increases in premiums. We can't shift any more cost to our employees. We don't really wanna pay that much more than our fair share. We certainly know that our federal and state governments are saying, we can't put any more into this program, and there's been a lot of downward pressure over the years, because this used to be even more lopsided. But the reality is, and this is a discussion for those doctoral students, we and I mean a global we, have created a system that no one can afford. Certainly not employers, not the government, and certainly not individuals. When individuals are going bankrupt, paying their healthcare bills, it is a system that some predict is on the verge of imploding. But in the meantime, this is how we are paid. And so I'm getting a little beyond the topic of this conversation, but it is a lot bigger than all of us. I'm going to give you a specific example, and again, these are Bothwell numbers. So let's just take a total joint replacement. And I have, not identified, you can see the different ways that the different amounts we are paid for the same total joint. If they were all the same patient, these would be the different amounts. And I put in yellow what the cost of the actual prosthetic device that we put in. That's our cost. Now, again, charges me nothing. Not what we charge, but our cost. And you can see how much of what we get paid by different payers is already taken up before we've had the operating room crew, before we've had, the cleaning crew, before we have doing the procedure in a place that has a cafeteria and all 24-hour emergency room. So it's kind of goofy financing, but that's what that cost shifting looks like with a particular procedure. You couldn't have, really no one designed this, and you can tell by the goofy way. This is Bothwell's audited bottom lines from 2010 to 2024, actual audited, and then that last number is our current budgeted number. But you can see that last year was the first year since 2018 that we made money on operations, so that's that dark blue line. You need to go back to 2016 to see the last year where there was a positive total margin. So total operations with investments and providing patient care. Current budget has us having a positive operating and total margin, but we are very much struggling to get back on track with our budget. Last year did represent an $8 million turnaround in reducing cost structure, and that was primarily due to qualifying for 340B. All that is a program where if you qualify, if you provide a certain number, you have higher numbers than normal of care you provide to Medicaid patients or disabled, but you can buy outpatient drugs some outpatient drugs at a discounted rate. So some at a discounted rate, and that we're saving about $8 to $9 million a year. So it is doing exactly, that program is doing exactly what it was designed to do 18 years ago when it was put in to be, and save rural hospitals and those hospitals that serve vulnerable populations. 340B is under attack, And it's interesting because there's no federal money that goes into, that's another form of subsidy for rural hospitals. But there is no, it's not being subsidized by the government or our tax money. It's being subsidized by pharmaceutical companies. And they're the ones that are, I'd be attacking too if I had, just our little dot on the map is saving $9 million a year. Just think about that. So I mean, it's obscene, but it is. But the reality is that if you are a rural independent hospital, you are literally on the bottom of the healthcare food chain. There is money to be made in healthcare. You can point to all kinds of examples, but it is not rural independent hospitals. So some of our strategies are how do we move up into the food chain? And we'll talk about that in the fourth segment where Cliff is leading us through on, okay, now what? So we know all this is what we have to live with. What are we gonna do? Because we have an important gem that we have to protect and keep being successful for 95 more years. This is just reiterating in a different way what Eric already said. Every 6 weeks, on average, a rural community loses its hospital, either through outright closure or converting to a non-inpatient model. Even more than that, stop certain services. There were 293 hospitals that stopped offering OB services between 2011 and 2023. 424 stopped doing chemotherapy between 2014 and 2023. So that doesn't even count the ones, that they didn't close, but they dramatically changed services. This is a map of what Eric was talking about, and we're on that list of vulnerable for closing. If you look at the most current data, it shows us making money on patient operations, but our total margin is a negative. When Eric talked about that this is being experienced by every rural community and every rural hospital, and certainly if you're an independent rural hospital, it's not a moral failing or a mismanagement, but it's rather a systemic issue of how we as a country are reimbursing rural healthcare. So it's, reimbursement below the cost. We're too large to be critical access. We're too small to be efficient with that volume amounts that Eric talked about. Costs rising faster than reimbursement. More employees needed to do all of the prior authorizations and fighting of denials needed because of all of the managed care plans, tracking of the quality measures, and it's also our desire to remain proudly independent is also contributing to the whole equation. And I didn't want to just sound overly dramatic without providing some evidence, but when rural hospitals close, people literally die. And I pulled out one of the articles that talk about that when a rural hospital closes, their patients are more likely to die, whereas urban closures had no measurable impact on mortality. But when you think about it, the further you have to travel, when you have any of those time-critical diagnoses, the higher likelihood is you're not going to make it to the hospital. So I was just recently interviewed for a national article on the financial pressures on rural hospitals, and when we got done talking, the writer said, "Oh my God, why do you do this? why do you stay in it? This just seems like impossible task. And I said, you know, if you didn't love it so, you would be curled up in the fetal position in the corner. But it's because and you heard from my intro, I took a 10-year detour from healthcare. And so I've chosen healthcare not once but twice. And that's because it's the only place where I feel like I'm doing something that matters, that I have purpose, and it's for this reason, we have to get it right. Because it's very personal when you are in a rural, independent hospital, because you're taking care of the people you know. So we have got to get this right, and we will. And otherwise I'd be in the corner in the fetal position if I didn't have hope. But it is gonna take all of us working together, not against each other, and on all fronts, because it's not one thing, it's gonna do 20 things that help rural hospitals. Okay, now it's my turn to take questions, otherwise we...
Questions for Lori? You guys are taking obviously good notes.
Just wait till the end. No.
Lori, thank you. Marvin, you're up.
I hate that picture. That's good. I really do, I really
We can
do.
do another.
What's that?
We can do another one.
I know, we probably should. So I know many of you in the room, and you may have heard me say this, when I joined Bothwell a couple of years ago, about 2 years ago at this time, I got a call from a recruiter that said, did you want to go to Sedalia? I said, I've never heard of Sedalia. He said, how about working at a Bothwell? I said, what the heck is a Bothwell? I had no idea what it is, but in the last 2 years, I've really learned what a Bothwell is. And what a Bothwell is we have a large service area. Our primary service areas are in Benton and Edison-Benton counties. We have clinics in Sedalia, in Lincoln, in Colcamp, and Warsaw. We had some outreach, but we pulled our outreach back from Marshall. But we provide services in many different communities. We're one of the largest employers in the city, if not the largest employer in the city. 450 staff members, 200 volunteers. I mean, this community really circles around what Bothwell brings. And when we look at, we have 28 specialties, 3 walk-in clinics, and I think we actually have more than 25 specialties now. Amber? Yep, Amber said yeah. Amber said yes. But I'll tell you, this really focuses on the breadth of services that are provided here in our community. I mean, we'll talk about the complexity of care. We'll talk about the role within the community. But for me, my experience here has been one that has not been touched yet. And I come from rural healthcare for many years, so I want to be able to talk about that. We serve we have 284,000 visits with 52,000 unique patients. You know, we have 24,000 ED visits every year. That's an extraordinary number when you consider that's the population of our community, correct? That 24,000. So when you look at the importance and you look at the fulcrum that our hospital and clinic system is, again, it's quite impactful. We have over 450, I think actually it's about 530 this year is what I've been told. It's been a busy year out there. I think there was a couple cold nights early on in the year. But again, when you talk about the impact on life, and when you talk about the choices we have to make and the services that we provide, when you talk about just what is a Bothwell, this is what Bothwell is. Bothwell is this linchpin within our community, and you can't really talk about the hospital without talking about the clinics. You heard about margins being thin. We talk about the complexities of billing. We say, why does it cost so much? Why is Bothwell buying that building? Why are they buying that practice? Why doesn't Dr. Eldenberg have his own practice, and Dr. Doak have his own practice, and Dr. Azan have his own practice, and Dr. Woolery? With all these things that we were used to have happening, Well, about 10, 12 years ago, physicians very quickly found out that there's a barrier of entry. It costs too much to try to run their clinics. One, they don't have the scales to really navigate contracts. So for us, having 284,000 visits a year, insurance companies go, yeah, okay, that's somebody we'll work with. When you have a smaller clinic that stands on its own, the insurance companies look at it and go, I don't care if I lose you or not, so I don't have to give you any benefits. Physicians started seeing that, and they started coming to the hospital saying, how can we still serve our patients but not lose our shirt at the same time? So it's interesting that really changed, and there's still some specialties that maintain their own clinics and independent clinics. But when you think of a PET scanner costing $2 million plus, machines costing $1.8 million, when you look at all of the costs of just having the diagnostic tools necessary to provide care to people, the independent clinic really can't always do that. So we really have to focus on what we can do to continue to grow. Clinics provide access. When I was hired here, the number one word, and you can ask anybody who was in my interviews, was access. I'm passionate about access. It hurts me when people say, I tried to get into my doctor and it's 53 days till the next available visit. I tried to get into that specialist and it's 13 months till I can get there. Those things pain me. Those things pain me greatly. And when we look at clinics, they're really our front doors. So we have a number of front doors into a Bothwell system. And having more clinics and having the right clinics is really the key to having those open doors and having access points across all of our communities. And what's interesting is that in rural communities too, I'm just going to say it, I don't want Golden Valley here. I don't want Fitzgibbons here. I don't want these other programs here, because this is my community, my Sedalia, and I know that I'm going to treat my community members better than anybody else can. And that's an interesting thing, and we'll talk about that when people leave communities to get care. It's not necessarily higher quality care, but it's a specialist to whom they're trying to see. Clinic-based care is lower cost. Who here can afford the cost of health care? Yeah, I don't see a lot of hands. Lori talked about it being a broken system and an unaffordable system. Eric talked about margins. We're talking about closures. Clinics are fortunate places where, while we get paid a little less in the hospital, we can actually have less overhead, and it creates an opportunity for more people to be seen at a lower cost. Because when the care is provided at a higher cost, that's passed on to our community members. And then again, bankruptcies occur. If I have a $10,000 deductible, that's $10,000 out of my pocket. If we can keep that cost of care lower by acquiring clinics and moving services to our ambulatory space, we're going to be in a much better position. Again, we want to leverage infrastructures and economies of scale. I believe we have, how many people do we have in HR? We have 5 people in HR that cover 23 clinics, 1,000 plus employees. That's leveraging economies of scale. If we didn't have those clinics, we'd still have 5 HR. So when we look at creating efficiencies, when we look at creating opportunities, not only in billing, not only in working with our payers, not only in how we can make purchases, because we're part of a group purchasing organization. So again, the complexities of healthcare are there. When we look at IT as well, and shared staffing opportunities, Ashley is a manager with us. How many times do you shuffle personnel around? Multiple times. Having multiple clinics allows us to do that, so that if one clinic is closed, or if one clinic is down a provider because they're on PTO, and if this year you looked at it, they're maternity. We have 9 physicians and APPs on maternity in the last 6 months here. But when you look at that, we have the opportunity of cross-training, standardizing, and really focusing on how we can move people around. That gives us that leverage of cost that, again, a small clinic does not have. So we want to bring these access points here so that we can leverage these things. Eric talked about social drivers of health, whether it's called social determinants of health, social drivers of health, health influencers, or non-clinical risk indicators. It has many names. but really it comes down to population health. We are walking well. So some physicians get really excited about working in the ERs because they want that excitement. We have a lot of physicians who say, I just want to keep care of the walking well. So I'll do sniffles, I'll do colds, but I'll do those well checks so that I can control your hypertension. I can control your hypertension. I can control your diabetes. I can take these chronic conditions and make sure that they don't turn into something that I need to go to a super expensive hospital for. And again, not just ours, but any hospital. Chronic disease management needs to occur in the ambulatory space. We need to tighten our hugs around each one of these patients. And we've done that in the last year. Population health occurring in the clinic space reduces that total cost of care and provides us opportunities to understand the needs of our communities. The social determinant of health screening tells us about food insecurities. It tells us about transportation insecurities. It talks about people with behavioral health and substance use disorder, as we've talked about. It gives us a picture of that 80-20. And to me, that's one of the more powerful things to talk about, is that 80% of the wellness of an individual falls out of the clinical realm. I mean, that's pretty incredible. And our clinics give us an opportunity to address that. We have done over 36,000 screenings, I think, to this year. Who knows more about the population they serve than a community of clinics and a hospital that actually is asking these questions? It's a very powerful thing. And what's interesting to me about having the clinics as well is that it keeps people from foregoing care. So again, we've all heard the stories of, and I have a father-in-law that'll do it. He's like, I haven't been to see a doctor in 40 years. Well, heck, we better get in and see a doctor. What are we going to do here? And you go in, he's got uncontrolled hypertension, his diabetes is off the hook, he doesn't know why his foot hurts, but he's got neuropathy, he's got all of these things because he's foregone care. Keeping clinics in our community provides that access, because when we forego care, we actually we increase mortality rates and we forego lives. It is critical to have these clinics. And again, while it's complex on how we choose our specialties, if you look at the makeup of our clinics, we have more family medicine with OB than any other specialty within our system. And the reason we do that is they're caring for the breadth of the patients that we have. And they have the ability to then refer them to our specialists. We have general surgeons, we have orthopedic surgeons, we have neurology, we're getting dermatology back. Getting dermatology back? All right. Getting dermatology back. But it's our family medicine group that really supplies all of these patients to our specialists. And a lot of times we get asked about the clinic side is, what is the right clinic? Who wants to, people say, I want to have cardiology here, why don't we have interventional cardiology here? I don't like driving to Boone for this. Well, I'll tell you, it's our population. And that's, again, when we choose our clinics, we choose it for the right complex reason. Because if I am going to have my heart taken care of, if I'm going to have my child have a cardiologist look at them, and they're doing 50 of these procedures a year, I'd much rather bring them somewhere larger and say, hey, you're doing 1,000 of these a year. I know you have the practice, I know you have the ability to do it. That goes into the choices of why we purchase clinics too, and why we may not purchase clinics or bring specialties in. So again, it's a very complex way of looking at things. Again, strategic defense and I'm not going to that. All right. Strategic defense and consolidation. This is really kind of quality control. We talked about standardization. We talk about the ability to really get things right, get them consistent, and remain efficient. Having clinics allows us to, again, that scope. In meeting and working with our lab director just the other day, she said, I want to make sure that this type of test is done the same way at each one of our practices. We embrace that. Now I don't have a quality concern saying, oh boy, they're going to get that test done at Clinic A, that's going to be fine, but if they get it done at Clinic B, oh my gosh, what's going to happen there? We're actually increasing the quality of care, increasing the quality of efficiency. Like I said, we want to focus on the fact that encroachment of other systems doesn't necessarily increase the quality of care. What it actually does is it furthers some of the insecurities that we have. If I have a transportation insecurity, I can't go to Clinton. If I have a transportation insecurity, I probably can't get to Boone. I can't get down to, or I can't get up to Fitz. So somebody comes and gets their care and then they get referred to a hospital away from here, they're again going to forego that care. It's important that we keep local care local. And that's again why we keep these clinics around. Margins may be thin, changes may need to be had in how we create access, but without the clinics, people are actually not going to get to our hospital. And when they do, they're going to be much sicker and they're going to take longer to care for. And as we've talked about, we don't have the RNs, we don't have enough physicians, nor do we have enough people to take care of more people that are sicker within our facilities. We also want to talk about risk mitigation. How many hospitals are going to close, or at risk of closure?
404.
So if Fitzgibbon closed, where are all those people going to go for care? And can we fit them all into our hospital? No, but we can probably get them into our clinics. So again, when we look at our opportunity to care for communities, to care for patients, it really starts at that front door of our ambulatory practices. That ambulatory setting allows us for an effective gives us an effective manner to embrace people, to care for people, and to then refer those people to the right level of care that they need. Hopefully that's local, but when it's not, we have partnerships with so many different hospitals. We have transfer agreements, and we have friendships. So that way, a CEO can place a call and go, can you guys just accept this person back? And that happens. That's what real care is about, and that's what we try to go for. But ultimately, I want to make sure that we try to, where we keep local care local. I always say it's a wonderful burden. And the reason it's a wonderful burden is because I feel compelled to provide the people I love, the people that I know, the people that I see every day with the best quality of care. It's a wonderful goal to have, but it is burdensome. It's burdensome when you are taking care of your best friend from growing up's dad, because you know a lot about them, but they're still your best friend's dad. There's a burden behind that. But when you look at what Bothwell is, both on the hospital side and both on the clinic side, that desire to keep care local overcomes that burden, overcomes that challenge, and overcomes that almost fear sometimes of, how am I going to care for my best friend's dad? Or how am I going to talk to my best friend when I have to tell him that his dad has dementia or cancer or heart disease or anything? It's a wonderful burden that we're able to continue to move forward and press upon, because we have clinic access and we have hospital access in Sedalia, again, Lincoln, Cole Camp, and Warsaw. So I thank you. Anybody have any questions for me?
We have plenty of time.
Yes.
Thank our panelists for being here. I think everyone knows how important the hospital is to our community. There's no question about that. We're not going to be the same community without a hospital. And I think it's obvious that there are many challenges ahead of us as an organization and as a community. And this is very real, folks. So from your perspective, and I'll direct this to our presenters, but also we'll just open it up to the group. You know, what do we do? Where do we go? What do we change? Ideas, thoughts?
I can start, because we've been thinking about this for many years. And then if you guys provide color, it's multi-pronged. One is to look at every opportunity, how do we reduce our cost structure? Certainly 340B qualifying for the first time, and it was 2.5 years ago, I think, was the first step. I think in my career, I will always have an active financial recovery plan. It's just the way it is. But I'm very excited about a step that several independent hospitals are taking in Missouri. We are banding together and we're forming the Missouri Independent Hospital Network. We're all in the process of signing engagement letters now. They have to be signed by October 30th. And November 7th, we engage with a company called Cebolo. It's not really a company, it is a non-for-profit organization. And Cebolo has done work just like this in North Dakota, Minnesota, Ohio, Montana, Nebraska, and Wisconsin. And they help us, we form a separate legal entity where all of us independent hospitals are board members. And we make decisions about how we want to run this independent network, but we form a clinically integrated organization. So it can then negotiate with insurance companies, engage in shared savings arrangements, but we'll also look at how are there shared services we can do. Whether that's doing credentialing with payers altogether instead of, I have a whole list of all the things we contract out to other people. Well, how about the co-op have their own, and any profit is then shared amongst all the co-op. We do that right now with our malpractice and general liability insurance. There's 40 hospitals in the state that band together and started their own malpractice general liability insurance company. And instead of being for-profit, it's not for profit, and all of the overage is distributed to the owners. So it's the same like a farmer's co-op that we're creating so that we can move up in that food chain. I think we should start our own pharmacy benefit manager. I'm sick of giving those middlemen money, and I'd like to have the co-op create our own PBM. So that starts November 7th. We launch the phase 1, which will be a assessment of each individual hospital by Cebolo, while at the same time I think for sure it'll be 15 different hospitals, if not up to 24 realistically, that will be founding members. And while the assessments are going on over 3 to 4 months, we will form a legal entity with some advice from an antitrust lawyer and launch the hospital independent network. So I'm very excited about that. So that's reducing cost structure. Looking for alternative revenue sources, whether that's congressional earmarks, which are now called community funding projects, a state allocation, which one of our neighboring hospitals just received one this last legislative session. The Rural Health Transformation Fund that was part of the OB3, or One Big Beautiful Bill. Our state, I think, is going to write a very competitive and compelling application. One of the things that's being pointed to on a national basis is our experience being one of the 6 pilot hospitals with the TORCH program, with the Medicaid program. So Marvin and one of the people from the transformation office within Medicaid are going to, I think it seems like around the country, talking about the accomplishments and how you can do this with partners in your community. Tax subsidy exploration, although that will take probably some changes in legislation, and any kind of tax subsidy on the part for Bothwell will require a vote of the people, a ballot measure. And also looking at more joint ventures and co-ops like the independent, or we're looking at maybe owning our own laundry between several hospitals, and then taking the existing 15 contracts with other hospitals and having that as an alternative revenue source for ourselves instead of a private company. We have entered the era where philanthropy will play an ever important role. Keeping up with technology is one of the very important roles philanthropy can have. We don't get paid one extra dollar for having the latest version of a LINAC or for radiation oncology. But certainly our cancer patients deserve the same precision when it comes to radiating your tumor as the other places that are able to afford the next best generation of LINAC. Geography should not dictate your prognosis. That's the role that philanthropy can help us with. Grants, we are always looking for opportunity for grants, and globally fighting and advocating for a federal change in reimbursement, updating how Medicare and Medicaid pays rural hospitals, ensuring Medicare Advantage payments are timely and fair, cutting the red tape around prior authorizations. Do you want your physicians and nurses on the phone on hold, or do you want them providing care? That's one question I asked. In tailoring regulations to rural realities, you talk about the regulatory burdens and having flexibility in staffing and reporting requirements. So keeping, that's just on my list of many things, and because we talked about, oh my God, look at this. Well, this is reality. What are we going to do? And so I think it's having strategies on multiple fronts. Eric, what do you see?
Well, I will share with respect to the municipal subsidies. I will share something I encountered a few years ago. I think this is in my deck on hospital closures. I had it just for reference. But something I noticed a number of years ago, and you can see this. So this is the hospital closures that have occurred over the last 20 years. And as you can see, it's very heavily Eastern and Mid-America oriented. But with respect to municipal subsidies and tax subsidies, a few years ago, it's been about 10 years ago now, I had a client in central Iowa. That was a new client to me. And so that was the very first time I had actually encountered a hospital in that state. If you'll notice, of all the hospital closures around them in other states, and Iowa seemed to be immune to hospital closures. And I asked, one of the very first board meetings I was in, they voted on increasing their mill levy to whatever percent it was. But that hospital, as well as all the other municipal-owned hospitals in the state of Iowa, had some sort of tax subsidy from the community. Nobody likes to talk about those, but in the era that we're operating in now, it's a very real discussion for the next 5-10 years. Is that something that we need to do? Is to talk about protecting the asset of the community through municipal subsidies. Also, we'll show. I put this in just as reference too, but you can see how important, just on a national perspective, generally speaking, for every hospital physician that's employed, there's a ripple effect or two positions outside of the hospital that's generated because of that one inside of the hospital. 10% of total employment's related to Missouri hospitals. Marvin mentioned earlier that 975, almost 1,000 positions now in the community. So again, the direct impact, both nationally and then regionally to this area, is probably another 2,000 jobs that you don't even see. But again, it's tied to this community. And then the uncompensated care, $5 million that we provided care last year, didn't get a single dime on. So my point is that of all the potential things we need to be talking about into the future, I think that's probably one of them. Nobody likes to talk about it, but again, it's in the interest of protecting the asset of the community. Marvin mentioned earlier, that hospitals that lose their, or communities that lose their hospital has a direct impact on the overall healthcare, not just delivery system, but the residents of that community are impacted directly. And then the economics obviously follow the loss of jobs, the loss of hospital. Another thing I spoke to a few years ago is that if you look at your paycheck and we have money taken out of our paycheck sent to Medicare and the federal government, that money comes back to this community through Medicare payments, through Medicaid payments. In the absence of having a hospital, those communities send their dollars out, but they don't come back. So this hospital is a vehicle for reinvestment of your tax dollars right back into the community. So all that is just to say that, if we're going to talk about sustainability long-term, I do think that is part of the discussion. It's not a silver bullet solution, but I believe it is something that communities need to consider, especially of this size.
Thank you. I just will add, there's advocacy, there's different things that we're doing with our legislators, there's different formations that we're looking at from a business perspective, but ultimately, what we need to do is start changing how healthcare is delivered and consumed. There's programs that do inpatient care at home. There's telemedicine services that can connect people from disparate communities all over the country. They can with specialists. We need to focus on what people find important, because we are actually in the business of sick care. We're not in the business of health care. We're in the business of sick care. We are treating people when they're sick. That is not cost-effective way of doing things, but we have to shift the culture on how healthcare is consumed. And we have to train and educate our communities on the fact that they can have high-quality care even if they don't step in that clinic. They can have high-quality care even though they're in their car. During COVID, it opened doors to see how effective virtual care is, but really at the highest point, only about 3% of all the visits were done virtually. So it was still a very small amount of services, but the impact and what we learned from how we can deliver that care is phenomenal. It is up to us as an organization, and it's up to us as a healthcare industry to look at how we can lower the total cost of care. Because as I said, we pass that on. If there's the gas, just like when I get gas, they pass on the taxes to me. If I go to get a TV, they pass on the taxes to me. Unfortunately, healthcare has to do the same thing. So if we don't focus on the care delivery, again, high quality care, lower cost of care, more ways to connect with our communities, if we don't do those things, then it is going to be a runaway train. And we can't afford the overhead of new hospitals all the time either. A hospital replacement is $400 or $500 million. The one in Fargo was $1 billion hospital. So, and we call it the Death Star. I don't know if you ever did, but it was just so big. But the fact is that we don't have the ability to continue to dump money into an infrastructure unless change is made on how healthcare is consumed and on how healthcare is delivered. We are leading the way. We're focusing on delivery of healthcare in a virtual world. We're focusing on bringing people from a virtual standpoint to their behavioral health providers. We're looking at the social drivers of health that we had talked about before in a way that is really getting the attention of our entire country. And we, as Bothwell, are literally the focus of what does a successful program look like. And so educating people, looking at how we can deliver care more efficiently and do it with less overhead, meaning less hospital space and sometimes less clinic buildings, but then educating people to know that that's high quality care that they're receiving at the same time will help us deliver that care and keep, again, care local.
Thank you, excellent. I expect that everybody that's, oh, go ahead.
I have a question.
Sure.
With the goal of creating the cooperative, a community response that would probably help you guys benefiting from being comfortable with having a virtual doctor that would be part of that network. Is that kind of part of the goal when you join? Do you have the ability to do that?
Well, we have the ability to
Yeah.
do that, but we have the ability, you don't need to form a co-op to, share a specialist. So we've had, I remember when, Dr. Anders first started and he was still growing his practice here, he went up to Carrollton, several, and that happened through a, you're gonna shake it, that didn't help. I think we need we need a new battery. That was just happening to be in Missouri Hospital Association meeting, and the Carrollton CEO said, do you have any pulmonologists you could send up? And so we do that, anyway, but yes, the co-op is, I think part of the assessment phase will be asking questions like that, where you only need a fourth of a specialty. You don't have enough volume to hire a full-time, and they'll identify where they're geography-wise, where that might make the most sense. So, yeah.
Good question. Others? Well, I expect that, can everybody hear me okay? Yes, Elsa.
I was just gonna make a comment, in alignment with the economic benefit of the hospitals in our communities. Coming from the community college in Sedalia and overseeing the health science programs that are at the community college, and there being so many rural community colleges in the US. I mean, there's multiple in Missouri, but in the US in general, we rely on the rural healthcare systems to partner with us to educate the healthcare workforce. So if we don't have that resource, we cannot educate the up and coming youth in our community, the adults who want to change their career path. I mean, just putting that out there. I know there's a lot of economic impact, but there's a lot of downstream impact too that would be very damaging to the educational realm as well. So just putting that out there.
I will say that the partnership with State Fair Community College, it goes both ways. Community health workers, they have a training program for that, one of the more robust training programs that has a direct impact on our patient population. And I would also say, not only for State Fair Community College, but when Nucor came in, I guarantee they said there's a hospital right there. When Duke is here, it's because a hospital is right here. And again, this shouldn't feel all doom and gloom. This is the complexity that we deal with day in and day out. These are the questions we ask all the time. It's what benefits both sides of this? What benefits our community? What benefits the hospital? What is sustainable and what is right are the questions we ask all the time. And the great opportunity behind that is that the downstream impact of the decisions that are made with our boards, with our foundation, the people, the stakeholders within our facility, patient family advisory committees. I mean, there are so many people that we're taking input from because we want to get this right each and every time. And then they're carrying that back to where they're at to talk about, hey, this hospital is doing great, or they're actually listening to me. They're actually trying to be better. They're actually explaining things in a way that I listen and I understand. And that gets to employers when they start asking the community, should we even go to Sedalia? Well, you're darn right you should go to Sedalia because they have this, this, and this. And fortunately, we get to be part of a healthcare system that has been anchored here for almost a century, that provides, guidance, provides care, it provides, the opportunity for people to learn, to be educated. We have CAP students, so we have programs with Smith Cotton High School. We have the only we have the only rural residency program in the state. I mean, this is a heck of a program to be part of, and it's a heck of a program to support, but it goes both ways. So I thank you at the college too, because you're always open to every pressure we have, so thank you.
Any other thoughts or questions? I expect that every one of us is here because we recognize that this is a serious issue and that we care. And so my question to you all now is, what can we do?
Well, I just mentioned the Patient Family Advisory Committee. What we have to do is talk to us. You have to tell us when it's good and when it's bad, not just when it's bad. Answer surveys so we can see how your care went the day you were in there. This is not us telling you what care looks like. This is us listening to what care needs to look like for our communities. And if our community voice is silenced, the hospital can't improve. The hospital can't do the things to expand. If our community doesn't tell us what we need or what they need, then we can't have conversations like this that say, we want to know. Be your own advocate, because we will advocate for you at that same point. But if your voice is gone as a community member, and if our voice is lost as a community, we can never do anything as a hospital. So I beg you, don't ever let silence be the way that you come into our facility. Let yourself come into our facility with thought, with desire to make change, and know that we will listen to you so that way we can get there.
I'll continue that ad for our patient family council. There is a flyer out on the table of how to apply to be on that, and we are looking for additional members. They meet monthly, and we bring issues to that council that we'd like to hear their perception on, because sometimes we think we know, but it's not until we ask the patient or a family member, well, what's important to you. So also of how you can help is use us for your care. As I was looking at Golden Valley and Clinton is doing really well. I wanted to see, well, what's different about, one of the things was their market share. They have a similar services they provide, but they have 90% market share. Our market share is about 75–80%. When Dorinda from Warrensburg and I talked, the Warrensburg people have a love affair with Lee Summit, and our people have a love affair with Columbia. So our driving past our clinics and hospitals and going to have services that we provide. We provide wonderful warm handoffs for services that we don't have here. But I'd say, use us for the services we provide would be one way.
That was exactly what I was gonna say, was, hospitals do a great job of responding to crises, but as a community member, and as, for those of you who have health insurance, use it. Don't just wait to go to the hospital when you're in crisis. Marvin mentioned earlier that, we need to do a better job of engaging, and I think Bothwell's definitely moving in that direction, but, and I could take this advice myself, but use your hospital for, maintaining health, not just going there when things get bad, because, as we've seen, statistically, the delay of care makes things worse for you, but it also makes things worse for your local hospital as well. So I would echo that to say, use your hospital. We've got, 284,000 visits. Let's go for 300.
Thoughts, feedback, questions, ideas? Well, one of the things that you mentioned in the presentation was remaining independent. Why is that so important?
Well, I can start. We even have it now in our mission statement. We hadn't before, and that's always been important. But I think, I know it's because we believe that decisions about care that's provided in our community should be made by people that live in our community and receive care here, instead of from a ministry or a corporate office somewhere else. That those decisions are not bestowed on us, but are created by us. But in the new world order, it's gonna be with partnerships and co-ops, because we want to create, in essence, what large health systems have. They've spread those fixed costs in a way. They are collectively bargaining for, buying stuff, but really for negotiating with payers as well. So it's, we want the best of both worlds. Remain independent, but also be able to garner some size when it comes, but with not intermingling decision-making about care that's provided here or our financials.
Marvin, Eric? Anything to add?
It's tough to add, but if you want to look at what it's like being part of a health system, I often reflect, I was with Common Spirit Health. We had over 150,000 employees. We were based in Chicago and San Francisco. When COVID hit in North Dakota, we had to do what they were doing in California, and we only had 11 people per square mile across that state. But we had to shut down, we had to do all these things. The decision that was made too, for those who did not want to be vaccinated, is on one day they fired 15,000 people across the country. That's why remaining independent is important, because we lose our ability to control our outcomes, we lose our ability to control our employment. And so we look at that, we need to look at remaining proudly independent and remaining independent in a way where we leverage the partnerships of co-ops, but again, at the same time, that we're understanding that we can move faster, we can be more nimble in decision making, and then we can sit down in an audience like this and say, this is what we're doing, and this is where we're going. Because we have the autonomy to do that, we have the ability to do that, and the control to do that, versus, again, being told from San Francisco or being told from Sioux Falls, from Minneapolis, what you have to do, regardless of whether it fits your community or it just fits the overall system.
Well, you've kind of already answered this, I think, but I asked, what can we do for you? But everybody wants to know, what's in it for me? What can you guys do for patients and the community?
You want me to go first? Okay. Well, it's really carrying on the legacy of John Homer Bothwell. He was wired in such a way that he couldn't help himself, but get involved in the community. And he knew that one person with a bunch of friends could accomplish a lot. And so we try to keep that legacy alive. We just had a meeting last night of our Smart, Snappy Women Committee of Wear Red. We placed over, we got together with a bunch of friends and we placed well over 100 AEDs in Pettis County. We're now moving into Benton this next year. We were a regional resource during COVID. The governor set up his monoclonal antibody center on the 3rd floor of the hospital. We, with our National Guard friends, gave over 65,000 vaccinations, with the number 2 zip code being Kansas City, because it was easier to get it vaccinated here than in Kansas City. We are the Health Strand host for the CAPS program with Smith Cotton, hoping to get a whole bunch more people involved and interested in healthcare as a career, and then go to Smith Cotton and make it happen. And we are involved in a lot of different, I've always thought that we need to get out of the 4 walls of the community, of the hospital or our buildings. And we've been doing that in a big way. I was just reading our newsletter. We participated in the Farm Safety Day. We are certainly there at the State Fair, taking blood pressures, sharing our expertise in healthcare, community education like this, and besides being, we need to be a great example of a wonderful employer. Since we are the largest employer in the city, we need to take that holds a responsibility as well. So that's what we can contribute and continue to be an economic engine for the area. My goal is to make Jessica Craig's job easy.
It's a good goal.
Yeah.
Anything else to add before we close?
The only thing I would add, and what's in it for me is, healthcare is a calling, and it can be a calling whether you're in healthcare or not. And there's a power of, that you have to advocate for this health system, because that advocacy will actually help people that you will never meet in your life. It will help people that you'll never come across, but that will be there. So that's your voice, and that's the so what, what's in it for us is you get to impact people across a continuum that you will never meet for generations by advocating for the hospital, supporting the hospital, and supporting the operations that are there.
On behalf of the foundation, we want to thank each of you for being here. Let's please give them a round of applause. We have just a couple more minutes. Don't have to use them, but if anybody has any other questions or comments or concerns or anything that they'd like to bring up, this would be a good time. Okay. I do see a couple of foundation members in the audience, and I'd like for you to stand up if you would and be recognized. Come on, Doctor. All right, thank you for being here. If you would like to learn more about the Bothwell Foundation, you can find a lot of information on the website, brhc.org. Our executive director, Lauren Teal Payne, is right back over here. Raise your hand so everybody knows you. The panelists will be staying around if you have a specific question you'd like to ask them about or talk about. And with that, I see some snacks and water left. Grab those on your way out. And again, thank you very much for being here. It means a lot. And together we can make this happen. Thank you.